starting the timer, and here is your question. Okay, so if you have read and understood, kindly begin your examination station.
Yes, I will start by wash my hand.
Yes.
Hello, I am Mr. Ghaziri, one of surgical doctors here. Can I confirm your name and age, please, ma'am?
Tina, 65 years old.
Nice to meet you. Today, I'm going to examine your hands. It will include the look, feel, and movement, and asking you to do some special tests. If you don't mind, I will ask a nurse to attending as a chaperone, please. The examination will include exposure of your hands, forearms, and the upper part of your chest, including
Okay.
the shoulder.
Yes.
Okay. Do you agree with
Yes.
this? Do you have any
Yes.
pain at the moment?
Not much.
Okay.
Yes.
Yes. So I will start by general look. I will position in sitting position with your hands in the pillow, exposing as the previous part as I told you. I will start to take a general look for your hands. I will detect swelling in at the cubital fossa in the elbow. I will start to comment on size, shape, and surface, skin, and the presence or absence scar over this swelling. Also, I will look for presence of any aneurysmal dilatation. Then I will go to look for any signs of ischemia, form of bluish discoloration, and in the right hand, or ulcer, and presence in any edema of the limb. Also, any venous collateralization or dilated veins over the right shoulder. Then I will ask the patient, please, ma'am, do you have any pain in your right shoulder, please?
No.
So can you please raise your right hand upward to the side above the level of your heart, please? Then
Okay.
I will see there is a collapse of the swelling that present at the cubital fossa or not.
Yes. What does this indicate?
Yes, if we have a swelling, if there is a distal part not compressed and the proximal part compressed, this is indicate venous outflow obstruction. If the all swelling not disappear, this indicates central venous obstruction. Then I will go through. Now I will feel your hands. Maybe if you feel any pain, let me know. I will start by evaluate temperature of both hands by comparison side by side from distal to proximal. I will also palpate the swelling itself for any tenderness. I will also feel the thread in your swelling by my palm of the hand to detect the flow. I will also now I will feel the pulse in your hands in both sides. There is a possible absence pulse on the of the radial pulse. I can't feel pulse on the brachial due to masked by the thrill of the fistula. No feel pulse in the right hand. So if no pulse, I will go through evaluation by Doppler, detect which flow is present. Then I will assess also by obstruction or occlusion of the fistula. Then go with Doppler to detect augmentation of the flow after occlusion of the venous flow from the artery to the vein. Then I will go to assess the pulsatility of the AV fistula itself.
Yes.
Normally no pulse, but if there is pulse, it indicates outflow obstruction.
Good.
Then I will to assess. Now I am going to listen through your swelling by the cone of the stethoscope to detect the Berwi. Normal, there is soft, continuous systolic and diastolic Berwi. Then after that, I will go to listen through your heart to detect any murmur due to hyperdynamic circulation. Additionally, now I will assess the nerve supply or nerves of your hands to detect any insult regarding your hands. I will ask with short overview. I will ask the patient to make a fist and display your finger. I will assess now the sensation. Can you feel this center point of the sternum, and assess both thenar, hypothenar, and anatomical snuff box to assess radial nerve, median nerve, and ulnar nerve, and overview regarding the motor component. Regarding the median nerve, I will ask the patient, can you count with your finger, right side and left side? Then as regard the ulnar nerve, I will ask the patient to approximate your hands, then display your finger, and don't let me to push it for intrinsic muscles of the hand. Then after that, I will ask the patient, can you put your hands in front of you, will support the wrist, and push against the finger and the wrist to test the wrist extension and the finger extension of the patient to evaluate the radial supply of the motor of extensor muscles of the finger and the wrist. That's now I finish my examination. You can dress now. I will pass thank you for your time. I will pass my notes to my consultant to figure out your
Okay. Can you summarize your case now, please?
Yes, today I examined a man 65-year-old who is present complaining of bluish discoloration of the right hand and right arm. On examination, we detected swelling at the right cubital fossa, suggestive of brachiocephalic fistula, about 4 by 5 centimeters, with signs of puncture over it and bruises with no aneurysmal dilatation. And on arm elevation, complete disappearance of the swelling, suggestive of no outflow obstruction, no edema, no venous collateralization, but there is a bluish discoloration of the hand with coldness, suggestive of distal ischemia with delayed capillary fill. Also, on feeling the swelling, there is coldness and there is palpable sterile all over the course of the fistula, with augmentation of the right radial pulse after occlusion of the fistula, detected by handheld Doppler, and with palpable sterile with no hyperpulsatility. So my on evaluation of the sensory supply of the hands, no detection of numbness or motor weakness of the hand. So my differential diagnosis, top differential diagnosis is dialysis associated ischemic steal syndrome, but I will consider the other causes for further to complete my examination. After complete my examination,
what other causes would you consider?
Consider monomelic neuropathy.
Yes.
Yes, and
all right. How would you differentiate between dialysis ischemic steal syndrome and ischemic monomelic neuropathy?
Yes. As regard to the monomelic neuropathy, regarding the temperature, there is peripheral warmth, detected pulse, and usually the affection is related to sensory and the motor affection of both the three median, ulnar, and the radial nerve, especially to the previous motor component counting and the wrist extension and the intrinsic muscles of the hand according to ulnar nerve. As regard dialysis steal syndrome, will be gangrene, tissue loss, pallor or bluish discoloration, or ulcer. Also, there is absence radial pulse, distal pulse with augmentation on obstruction of the AV fistula communication or the compression of the.
What investigations would you do?
As regards the investigation, the most important duplex on the arterial and venous system of the limb, but I will also can give CT angiography, MRI angiography for
Yes.
further surgery.
Yes.
According to the management, we can reduce
Yes.
the flow by bandage or stocking or modulation by surgical revision. The other one is ligation of this fistula is not functioning, and declaration
Yes.
another one more proximal in same limb or the other limb.
Good. Very good. You covered everything today.
Thank you.
Very good.
Thank you.
Yes. Very well prepared. Very well prepared. Very good. Very good.
Thank you, ma'am. Thank you.
Anyone else want to give feedback? All right. And here is your question. Right. If you have read and understood, considering it critical care scenario, please tell me, how would you manage this patient now?
Yes, I will manage these patients according to the critical care of surgical irrigation protocol. I will assess first the airway and make sure that it's patent after talking with the patients, and then and then manage the breathing. Give the patient 100% oxygen and consider intubations by liaising with anesthetic if there is any compromise, and then assess the circulation of the patient. I will start giving the patient. As the patient is on furosemide with no improvement, so I will give the patient triglyceride,
Yes.
nitrate.
Yes.
And then I will assess the patients by
anything else? Patient is oliguric.
If
any diuretic, anything else would you give? Because here you have to focus on 3 factors: preload, afterload, and inotropic sport, because patient is hypertensive tachycardic.
Yes.
So yes.
I will give the patients other diuretic like spironolactone, and give inotropic support like dopamine.
Vitamin, okay.
Vitamin, and assess.
What would you give as an afterload reduction to reduce the afterload? What would you give?
Afterload.
To reduce the afterload, AC inhibitor, enalapril.
Yes, AC.
How much would you give?
No, above.
Okay, right. What else would you do? How would you assess the ventilatory support for this patient? Because patient is becoming tachycardic, desaturated. So how would you take care of that?
Well, patients will need the SPAP. It is and it is I preferred in patients with pulmonary edema.
Yes.
So I will giving the patient
okay.
SPAP.
Patient has been given approximately 7 liters of fluid. Do you think it's enough? Is it should it continue like this?
No, I should stop
yes,
giving
IV fluids immediately. Yes, you should stop.
Immediately.
Yes.
And
what might yes, please.
And then assess patients by detecting the by putting urine cluster.
Okay.
Urine cluster.
What is the normal urine output?
As 0.5 milliliter per kg per hour.
Okay. All right. When would you consider that the patient is oliguric?
When?
Yes. Why? when it becomes, what are the causes?
Causes of patients being oliguria due to
Yes,
the
please.
surgical. First, there is a surgical stress response leading to stimulations of catecholamines,
Okay.
which cause the salt and water retention. Also,
Yes.
there is also due to there is the stimulations of the vasopressin
Yes. And
from
third?
the and third, there is a there is due to the congestive heart failure.
Yes.
There is dilational heart failure leading to hypovolemia and oliguria.
Very good. Can you please explain the mechanism of oliguria when patient has pulmonary edema? How does it occur? Can you tell me the steps, all the sequelae?
Sequelae of oliguria, there is
No
as the
cardiac
patient,
output, then?
yes, as the patient, as there is decreased cardiac output, and there will be ischemia. There is decreased blood supply.
Renal perfusion, yes. Then?
So it will affect the glomerular filtration rate. It will decrease the glomerular filtration rate and in the glomeruli, causing
Yes.
lead to decrease dilution, decrease dilution and decrease urine output.
All right. Okay. Some points you have missed, you can read them later. Please tell me, where are you going to manage this patient?
Where?
Where?
Yes, in the intensive surgery unit.
Okay, HDU. Okay, can you tell me who would you involve in the management of this patient?
I would involve the ITU therapist and the ITU specialist and the IT specialist and the surgical consultant.
It's a post-op patient, so okay. All right. Can you please tell me what measures can you take from preventing this to happen again?
Yes, I will assess this good monitoring of the fluid I give by
How?
measuring the central venous pressure.
Yes.
Measuring the central venous pressure and the
Yes.
urine output, and also avoid excess administration of fluids, and good training of the junior staffs to deal with this, to deal with patient correctly.
Okay, and close monitoring.
And the close monitoring of the patients.
Okay. How would you measure? You said you'll take measures, so that you'll insert CVP line.
Yes, I will insert the CVP line and the urine test.
You get as well. Okay. All right. Can you please tell me about the fluid solution? Patient was given 4 liters of normal saline. What should be the ideal fluid which should be given post-operatively, and how much?
In this patient or in general?
Yes, in post-op patient in general. This patient was given 4 liters of normal saline. Was it good enough? Was it right to give 4 liters of normal saline?
I should start with 1 liter and
Okay.
assess the patient. And assess the patient. Then and reassess and give, and then give. And if you need again, I will give 1 liter again.
What should be the ideal fluid or ideal solution to give to the patient post-operatively? Colloids or crystalloid?
Crystalloid and colloid.
Both.
First, crystalloid is the optimum Hartmann solution.
Okay. If you take chest X-ray of this patient, what would you expect to find?
Yes, there will be alveolar damage and beta Kerley lines and cardiomegaly and dilated prominent vessels, upper vessels, and pleural effusion.
Okay.
They are suggestive of pulmonary edema.
Can you see all these points in this X-ray?
Can what?
Can you see all these findings that you have told me in this X-ray? Can you appreciate?
There is cardiomegaly and there is pulmonary infiltrates. There is the cardiomegaly and there is.
Okay, can you please tell me how would patient present? What would be the clinical features?
There will be lung crepitations and puffiness of the eye and swelling on his face and confusion and the tachycardia.
And congested neck veins.
Congested neck veins.
Very good. Okay. Right, good. Thank you.
Thanks.
Yeah.